It is December 10th, 2024. I'm Dr. Duke Majan, CEO and founder of Duke Spine Institute. We're going to be performing thoracic spine Duke laser disc repair. Our patient injured his entire thoracic and lumbar spine in a work injury. He's had a fusion done from L2 to S1. We're going to later fix the L1-2 disc because he has that adjacent segment disease. But right now our focus is T9-10, T10-11. He's got 2 disc herniations with horrific pain right here. And that's where the T9-10, T10-11 discs are. He's got small tears with bulges. If you look at the MRI, you're going to say, I don't see very much, but we can see that their discs are definitely damaged, and that's where the pain's coming from. He's undergone facet treatments with the Duke plasma rhizotomy, and that cured his facet pain. Now he has disc pain. So we're going to get started, bilateral T9-10. First, I need to localize. So bear with us. Yeah, you can do a lateral. Let's go lateral. We're going to get to the T9-10 and T10-11. We know the screw is at L2, correct? So 2, 1, 12, 11, 10, 9. So that looks like 9, 10 right around there. Shot. Yeah, so 2, 1, 12, 11, 10, 9, 8. We're doing 9, 10, 10, 11. Everyone agree? So let's go AP. Bear with us as we get localized. There's 12, 1, 2. So 12, 11, 10, 9. 9, 10 would be right there where the arrow is. You guys see that? That's right where his pain is.
Yes, we do.
Checked it this morning. Shot? All right. You can see the disc does not look normal. It's got irregularities of the end plates. Show us the end plate irregularity. Right, show the arrow right along the end plate. Look how it's uppy bumpy. Go out to the other side. Show that sticking out the bone spur above there, right above there. Right there. That's touching the bone spur. There should not be a bone spur. All right, so I think we're going to be really good because I think this is where his pain's coming from. The 9-10 and the 10-11. So everyone agree, 9-10 bilateral, then 10-11. All right, that looks good. Let's go to a lateral view. I'm going to start by placing the needle on the right side. With the thoracic spine, you cannot go as wide as the lumbar spine. You have to start more medial towards the midline. We're going to be fixing 2 discs today. So 12, 11, 10, 9. So 9, 10. Wait, sorry. 1, 12, 11, 10, 9, 9, 10. That's pretty much where we're headed. All right. Thoracic is the hardest to fix of all discs. Shot. Jordan, is that 9, 10 up there? 1, 12, 11, 10, 9. Let's get 9, 10 a little bit better in view. Let's move the fluoro north a smidgen. That should be 9, 10, right? All right. Well, we're right on target. Shot. The first thing I'm going to encounter is the facet joint, and there it is. Shot. I'm touching bone. And let's get an AP. Let's see where we are. Now, because this patient has bad sleep apnea, we decided to intubate him, put a tube down, and keep him safe so he can breathe throughout the surgery. It's a long surgery. All right, so 2 medial. That's perfect. Let's just see where we are. 12, 11, 10, 9. So we are at 9, 10. All right, that's where we want to be. We're going to do this disc on both sides and then the next one down on one side. It's better to err a little bit medial than lateral. So we erred a little bit medial, which is what we want. Now we just got to work our way laterally. Shot. All right, let's go AP again. I may be hitting the transverse process. still medial, so it's still the facet, which is good. Okay, let's go lateral. I'm probably going to have to come up a little bit. I'm going to try this, but if I can't get it, I'm going to start up just a little bit. Up, yeah, up and out just a tiny bit. All right, shot. All right, so something moved, Jordan. Shot. Mm-hmm. Shot. All right. Shot. He must be on something that's causing some antiplatelet function. Shot. You think that's 9-10 there? Should be, right? Yes. Oh, shot? No? So we're not doing it Friday. Shot? That's fine. Shot? All right. Again, AP. He's a big guy. He's got a lot of muscle. We're going to have to figure out the right trajectory, and that's what I'm trying to do right now. Trajectory is the key. Yeah, so again, we're too medial. I'm going to have to be a little bit more lateral, which is fine. I could start just a little bit more lateral. Shot. Mm-hmm. As I said earlier, it's better to shot air on the medial side than it is to air on the lateral side. Shot. Got to just get past this facet. There we go. Shot. Let's get an AP. All right, now we're in the foramen with the needle tip. I'm going to check not just my medial position, perfect, but I'm also going to check my localization. So L1, 12, 11, 10, 9, I'm at 9-10. The lung looks good, there's no pneumothorax. Shot, Jordan. Okay, that looks good. Shot. Now, we're right at the back of the disc. Shot. Let's go AP. I'm going to enter the disc in just a moment, but I want to verify one more time on the AP that we're in the right position. If you're being pushed laterally, that's bad. I've been in that situation where the facet was so enlarged that it pushed my needle lateral right towards the lung, and I had to stop and abort the surgery. But not in this case. We're good. Shot. Okay, we're in the disc. I could feel it go through. We're going to place the next needle on this side. This will be the 10-11, correct? Sean? Any questions from our audience?
At this moment, no current questions.
Let's show the audience how it is that a thoracic disc herniation can cause. First of all, let's show the audience the 30 causes of back pain so that they can understand that there's not just one cause of back pain, there's 30 different causes. And then we'll show them how a thoracic disc actually causes back pain. Sean?
Copy that.
Well, these other needles. I'm Dr. R. Duke-Magin with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Majan. Thanks for joining us.
You see now that there are about 30 things that cause back pain, but they all don't cause it at the same frequency. The most common cause of chronic back pain and thoracic pain is a disc injury. Disc injuries include herniated disc, bulging disc, ruptured disc, protruded disc, extruded disc, slip disc, spondylitic disc, degenerated disc. All those are disc injuries that can cause pain. This patient has horrific pain right here in his thoracic. He says he can't even breathe at night to sleep. It hurts so bad every time he breathes. That's why we're doing the surgery. There is no other treatment for this except for fusion. All right, show us the irregularities of the disc. There's the first disc. It's collapsed. It's about 20% collapsed, and it's got an irregular end plate. The one above you could see is even more irregular. It's got kind of a bone spur sticking out. So these are not normal discs. They've been damaged, and they're definitely the cause of his pain, in my opinion. Shot, there's a discogram. All right, look at that. You can see the tear in the back of the disc. That's where his pain's coming from. Show us the tear. Yep, so the black dye should stay in the middle of the disc, the middle. That's normal in the middle. But once the part that's from, show us, Jordan, about the middle of that. From right about where the arrow is to the right, that's all a big tear. It's all abnormal. And that's where his pain's coming from. That's the 10-11, right? Shot? All right, and the 9-10 is full of scar tissue. I can feel it, and it's got a tear as well. All right, we're going to get started. We're going to start with the 9-10. Once again, the patient's asleep. We're going to go in and repair these two discs with the laser. What we're going to find is that there's herniation, annular tear, inflammation. Okay, incision. This is the larger. If you have questions, go ahead and ask them. Otherwise, Henry, show the audience how a disc injury can cause so much pain for a patient
Copy that.
while I make the incision.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Let's have some num-num. Now we're placing the dilator over the guide wire. We're going to advance the dilator in to the disc, and then we're going to use the laser to clean the tear. Shot? And that should get rid of his pain from the disc. That's what I expect. Now we've done about 25 of these thoracic discs patient surgeries over the last 4 years. And the pain relief we've been getting is about 99% at 1 year. 1 year after surgery, the patients have 99%. That's our average. That's really good. Basically, we're curing their pain, and the pain is not coming back. That's what the results tell us. We published that data several years ago. Shot? That's patient-reported outcomes. So we ask our patients how much of their pain do we get rid of. Shot? 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 I'm thinking we maybe do the smaller. Do you have it? Yeah. I can try this. Let's see how it goes, just for another minute. Shot. 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 We're just lateral to the facet joint. You think we're down the middle, right? Shot. All right, we're right at the back of the tear. All right, I'm going to enter the disc. Uh-huh. I know this looks horribly barbaric, I'm aware of that, but the reality is that it really works to eliminate the pain that these people just can't live with. And it's not this that does, it's the laser that does. That's good. How's he doing, Dr. B? Doing great. All right. This is a thoracic spine Duke laser disc repair. We're here to clean the tear with a laser that's causing his pain. It's a tear in the back of the disc. Have we shown the treatment, how it works?
Not yet.
Let's do that.
Of course.
Disc injuries are a common cause of chronic thoracic back pain. The inflamed annular tear causes thoracic back pain. A 1/4-inch size skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. The advantages with the Duke laser disc repair is that it's an outpatient procedure that takes 30 minutes to complete, very minimal bleeding and pain after the surgery with immediate recovery and return to work the next day, as well as a 99% success rate and permanent pain relief with a single treatment. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-BACK, 349-6922.
Welcome back. So we have already started the Duke laser disc repair. Look at the pink tissue right there, guys. That is where the pain comes from. It's inflammatory tissue. That means this man has inflammation in this disc, and it's the inflammation that's causing all the pain. Folks, if you don't know that, that's a very important thing to know. Inflammation is the cause of pain in your body. When you have inflammation, you're going to have pain. Now, inflammation can happen in two parts of your body. One part has nerves that go to your brain, where your brain will perceive it as very, very specific pain, where you feel the pain in a specific place. Okay, we call that localized pain. That's when the pain fibers project to the primary somatosensory cortex. It's the part of your brain that tells you that I have something wrong in a very specific place. Then there's pain fibers that do not project to the primary somatosensory cortex. Those fibers are called visceral afferents, and they do not go to the primary somatosensory cortex. Therefore, you do not get localized pain. Look at the herniation. Look at that thing, the blue thing, just sitting in the tear. Now, before you guys came back, there was some pink tissue. That's granulation tissue. And we're still seeing some here and there. We'll see more. But that granulation tissue is a 100% confirmation of inflammation. And when it happens in the back of your disc, there's a herniation right there. Look at that
yes.
thing. When it happens in the posterior annular tear, you're going to have very localized pain. If you have a herniation laterally in the disc or anteriorly, you get no pain that's localized. You will not feel it because those pain fibers are visceral afferents. The pain fibers that transmit stereotopic information to your brain are somatic afferents. Any questions?
No current questions, so we do have a comment coming from Steven on YouTube
Hi, Stephen. Welcome.
saying thoracic pain is unbearable. I live with this. It's life-changing.
We can fix you, Stephen. We can cure your pain. We've been doing it for years. This procedure, I know it looks barbaric if you're watching, driving a metal stake in, but the truth is it's part of the surgery. If it's done properly by an experienced surgeon like Duke Spine Institute surgeon, it can be done very safely. We've never had a complication. We've never had a complication from this laser surgery. Never. Not a surgical complication. We've had 0 surgical complications. Surgical complications are different than anesthesia complications. An anesthesia complication means the anesthesiologist has a complication, all right? A surgical complication means the surgeon has a complication. And they're very different. A surgical complication is like I cut something I shouldn't have cut, I punctured something I shouldn't have punctured. An anesthesia complication could be the patient stops breathing and has an issue. Or blood pressure issue, you know. So those are potentially surgeon or anesthesia complications. You know, blood pressure, if the surgeon cuts an artery, then he causes the patient to exsanguinate. That would be a surgical complication. But if the anesthesiologist gives the wrong medicine or dose and the patient's blood pressure drops, it would be an anesthesia complication. Point is, we've never had any surgical complications from this surgery in 19 years of doing it. We've been doing the thoracic DLDR you're watching right now for about 5 years, right, Luis? 5 years? I think we did our first patient 5 years ago. Now, I did the patient. I was scared to death. It's the first one done in the world. Nobody else in the world has ever done an endoscopic annular debridement on a thoracic disc. I certainly had not until about 5 years ago. And I was doing cervicals and lumbars, which are, you know, risky enough as it is. But I was too scared to do a thoracic. I didn't want a complication. But the patient told me something that resonated. We had tried everything with him. He had thoracic disc herniation from a car accident or a slip and fall. I think it may have been, I can't remember, some injury. And he was living in pain, constant thoracic disc pain. We did epidurals. He got better for a little while, but then the epidurals started working. And we did the rhizotomy with the facets. We did everything, but he still had disc pain. The only thing left to do was a fusion or laser. And he couldn't do the fusion. He didn't want the fusion. And he told me that if, you know, he couldn't go on living like this. And that told me that for some people, back pain is so severe that they will end their life. And I realized at that moment that people will end their life. And I didn't understand the gravity of the situation until that moment. And once I did, it really changed me. It was like an epiphany. It was like, wow, I never realized just how bad life could be for these people. They want to end their life. But I took it seriously. And, you know, I feel like, you know, God spoke to me at that moment and said, you've got to do the surgery. You've got to try to help him. It's his last chance. And I did it. And he came out of the surgery with zero pain. His pain was 100% cured. And he had no problems, no complications. And he was so thankful for it. I still remember his name. I can't share it with you, but I'll never forget him. And he changed the world for you guys, because now we do this surgery routinely as a result of him and his you know, his struggle and his bravery, his willingness to try something like this that's never been done before in the thoracic spine. So if you suffer or know somebody suffering with thoracic pain, bring them to Duke Spine. Let us fix them. Thoracic pain comes from a couple of things. It can either be a disc, or it can be a facet, or it can be a fracture, or it could be a tumor or an infection. Tumors and infections are easy to figure out. You look at the MRI, you can see them. But fractures are easy. You know, you just look at the MRI, you see a fracture. What's hard is the disc and the facet pain. By the way, all of this is abnormal right here that I'm shaving with the laser. 100% abnormal, herniation right there, scar tissue, inflammation. This is definitely the cause of his pain. I feel really good about this, and I think he's going to have a great result. Once again, our result for thoracic laser, Duke laser disc repair, is 99% elimination of thoracic pain from the disc. Any questions?
Yes, we have a question coming from Big John on
Big
YouTube.
John, I love it. Good to hear from you, Big John.
Saying, good afternoon, Dr. Light Switch.
Huh. Thank you.
I have a knee DPR question. Will a knee DPR treatment have any effect with either stopping or reducing crepitus of the knee?
So crepitus is, Big John, thanks for joining us and sharing. Crepitus means a grinding sound of bones basically grinding, and it comes from basically arthritis destroying a joint, and therefore you get a bone-on-bone rubbing. Crepitus is just a sound and a feeling of grinding. It is not pain. Crepitus does not equal pain. So if you're asking me if a knee DPR would get rid of the sound of grinding, I don't know. I don't know the answer to that. I would not do the surgery to get rid of the sound of grinding or the sensation of grinding. I would only do the DPR to get rid of knee pain. So if you're having pain in your knee joint and you're faced with surgery like a joint replacement, I would definitely do the knee DPR at Duke Spine before you get a joint replacement. All right. I am pretty much done with this disc on this side. I'm going to next go to the next disc on this side, and then I'll go to the left side. But we're done. We cleaned it up. This is the back of the disc right here. You can see the little veins in the epidural space. I'm just going to clean the last of this herniation with the laser. Just at 12 o'clock is the spinal cord, by the way. 12 o'clock, you can't see it, but it's right past that web of inflammatory tissue. Spinal cord, right in there. That's what makes this surgery so unpleasant for surgeons to consider, is that there's a risk of damage, and it's ever present during the surgery. The other big risk is a pneumothorax, a dropped lung with the needle placement. There's also risk of injuring, blood vessels and nerves. But everything looks great. I'm very happy. We did a great job here. We're going to move on to the next one. I think that's going to fix this problem right there. Scope off. We're going to put a little antiseptic, and we're going to move on to the next disc. Any questions?
No current questions, so we do have a comment from Big John once more on YouTube following up on their question, saying, my best guess, and would agree with you, I would say it would not stop the sound.
So Big John, I think it will stop the sound. I didn't finish your answer. But it won't happen right away. You see, what will happen is, if we can fix your knee pain in an arthritic joint that has crepitus, we can fix the pain and you can start walking around normally. I think you're going to break up the scar tissue, develop new types of tissue around the joint, and that's going to get rid of the crepitus, okay? But I could ask somebody what their thoughts are who's had the procedure and see if they have an answer. So I'm not going to mention names, but somebody in here had the procedure. Did you have crepitus? Grinding, sounds, all that?
Yeah, sometimes. Sometimes it'll pop a little bit, but I have absolutely no pain.
Pain is gone, but is the crepitus gone?
It's not
Popping is not crepitus. Popping is different. Crepitus is like a grinding. No? Did you have any before?
a little bit.
All right, so one of our patients who had the knee DPR says that the pain is gone and the grinding is gone, but she didn't have a whole lot. But she does have occasional, like a popping feeling, which, we can't fix that with the plasma rhizotomy. That requires, fusing the joint, or even, I wouldn't even replace it for that. But occasional popping is not something I would ever treat. Okay, one down, 2 more thoracic to go. You guys are watching history. There's nobody else in the world that does this. No other spine surgeon or surgeon. It's only done at Duke Spine. All right, we're going down to T10-11. And let's see, 1, 12, 11. Just for reference, show them, just come down and take a shot. Show them the screw at L2 and then count up. All right, you can see the screws at L2. There's L1, 12, 11, 10. So we are at 10, 11, and that's where we're supposed to be. You can go back, shot. I've placed the guide wire. Next comes the needle actually I'll make an incision, 7 millimeters. We're using the larger scope, not the small one today, and the reason is he's got big discs. He's got big anatomy. If he had some super collapsed disc, I would use the smaller scope and tube. But because he's got big anatomy, I'm using the big stuff. He's a big guy. He's a really big guy. Shot? All right, any questions, Henry?
Yes, we have a question coming from David on YouTube.
Hello, David, welcome.
Asking, you said you were afraid to do thoracic laser disc repair. Why?
Great question, David. Well, I'll be honest with you, David. Any good surgeon is afraid of every surgery they do. We're afraid because we don't want to hurt the patients. We don't want the surgery to cause a problem for the patient. If you have a surgeon who cares about you, they're always going to be afraid. They'll never tell you that. I will tell you because I believe in honesty and transparency. But surgeons should be afraid every time they do surgery. Okay? They should be. Because you're cutting a human being open and you're messing around with the anatomy. And a lot of times what you're messing around with is not normal. You're not messing around with normal things. You're messing around with abnormal tissue. Whenever you're moving around vessels and spinal cords and nerve roots, you should be afraid. Okay? Now, this is the safest possible surgery that could be done on the thoracic spine. But I still am afraid. And what I'm most afraid of in a thoracic DLDR is the spinal cord, epidural hematoma, pneumothorax, vascular injury, hemorrhage, pneumothorax, hemothorax. I mean, there's so many things that can happen. Spinal fluid leak. There's so many potential complications. Shot? So I worry for my patients. I don't want my patients to be hurt. And so that's why I'm afraid. The thoracic is the hardest. It has the highest chance of complication. Okay? Even though we've never had one, our numbers are low. This is probably the 26th or 7th thoracic DLDR we've done. So we don't have hundreds of these surgeries down our belt. Nobody does, because not many people have thoracic pain. It's not a common problem. Sean? But I'm just being honest. Every surgeon, no matter how good they are, should be afraid of any surgery they do. The easiest surgery we do as neurosurgeons is something called a sural nerve biopsy. It's where we go in the calf and take out a piece of the nerve that's there so that we can send it off for testing to see if patients have some type of a neural or neuromuscular disease, right? It's a biopsy. It literally takes 5 minutes to do. It's the safest, easiest procedure we can do. But that said, we had a surgeon once at Gainesville Shands who did a biopsy with attending, and the patient died during the procedure. Okay? They died of an anesthesia complication, but that's just shows you it doesn't matter what surgery you're doing. It doesn't matter how good the surgeon is. It could be the easiest surgery in the world. Patients can die during surgery. And that's what we are afraid of. That's what a good surgeon is truly afraid of for their patient. Sean? They're afraid of a complication.
We have another question
Sure, I'll take it.
coming from Adam on
Sean?
YouTube,
Uh-huh.
asking, what's the surgery for degenerative disc disease at L5 to S1?
It's the same surgery we're doing right now, Adam. Duke laser disc repair. This is the best surgery you can have done. There's nothing better. There is no surgery that will make your disc normal again, but there's surgery that will take away your symptoms completely and permanently with minimal risk to you. That is the best surgery you can do. And this is that surgery. There's no surgery that even comes close. Fusion is far more risky of complications, bleeding. Plus with fusion, you're going to need narcotics afterwards for a long time, months. And those narcotics are addicting. They have the potential for abuse, and you can even die from using them. Narcotic overdose, very common problem. With these surgeries we're doing, there's no narcotics used except during the surgery, which is safe because the anesthesiologist is doing it. But there's no need for narcotics after surgery. Okay, massive disc. Look at that thing, all that scar tissue. So this is totally abnormal as well. There's the herniation, it's blue. I can't even grab it out with the grabber. Nothing's coming out. I'm going to have to use the laser. Laser is far more effective than any kind of metal grabber. Keep the questions coming. I love them. They're great questions today. I appreciate you all being here and being involved. Again, we want to raise awareness that these treatments are available now in the United States for the whole world. We have people from all over the world come here for these treatments. Look at the scar tissue, the calcification. Totally abnormal disc, verified endoscopically. For those of you who don't know, the laser fiber there is a fiber optic glass cable, and it is 1 millimeter wide, 1 millimeter wide for your reference. It's actually 950 microns, which is just shy of a millimeter, but it's a millimeter. And the energy is released out of the tip of the laser. It's released right to where the surgeon wants it to go. And it's with a precision of 1/20 millimeters. So 0.05 millimeter precision. There is no surgery tool in the world, doesn't matter what you choose, whether you choose endoscopic, endovascular, radiosurgery, metal surgery, microscopic surgery, no surgery in the entire world is as precise as 0.05 millimeters. The only thing that comes close is surgery on the eye, the cataract removal, and this is the most precise surgery that can be done. And it's being done with a laser endoscopically.
We have another question
Sure.
coming from Adam once more on YouTube asking, how do you choose people to opt in to a live stream for their procedure?
We just ask them. So Adam is asking, how do we get patients to opt into live stream? We just tell them we'd like to live stream so we can teach other people while we're doing your surgery. Of course, we don't tell you the identity of the patient. That's something that's private. But the patients, not all of them agree to it. And the ones that say no, we don't live stream them. But the ones that say yes, we have them sign paperwork saying that, that way we have a record that they said we could live stream them. And we do all that before surgery while they're, have an opportunity to consider the pros and cons. But Adam, the truth is, virtually every patient you see here having these surgeries watched a live stream or more than one before they came here. So the truth is the live stream is very helpful for people to understand what we're doing and why we're doing it. And so we find it a very important educational tool. And as the CEO and founder of Duke Spine Institute, I believe patients should always have what's called informed consent as possible of all the options and then make a decision. It's called an informed decision. The truth is, though, I help them because I'm aware of all the choices as well, being a spine surgeon, neurosurgeon with lots of experience, 26 years. And, I try to guide my patients because it can be very overwhelming for somebody to try to understand what's the best option. That's why I don't offer people every single option in the book, because I don't believe in doing treatments that don't work. So I'm not going to offer something that isn't going to work. And when it comes to these types of problems, like this disc pain, that's a herniation, by the way, the blue stuff. That's degenerated disc. When it comes to fixing this kind of pain, there's only two surgeries that work. One is fusion, and the other one is the laser. Now, there are companies out there that want you to stick their spinal cord stimulator in your body. So they have basically created false studies that purportedly show benefits to their treatments, but those aren't real benefits. They're just basically paying the journals to publish those results so that they can sell these stimulators and make billions of dollars profit. We don't do that. We do treatments that really work. We don't just do treatments that make people rich. I'm not interested in rich. I'm interested in, fixing people's lives. That's really what I'm interested in. Of course, it takes money to do that. We don't have a charity arm, so it costs money to do these surgeries, a lot of money to run this place, but that's why we bill insurance when we can, and that's why we have patients pay when they can. But all the patients you're seeing, all of them have paid for surgery and have approved us to do their live stream. And we do that in advance. If they don't want it streamed, then we don't do the streaming. I would say 9 out of 10 patients allow us to stream. 9 out of 10 is the average.
We have another question.
Yep, this disc, by the way, look at all this. This is totally abnormal. So again, just like the last disc, when I got in there and I saw this, I'm like, yeah, this is definitely going to help this patient. You don't know, because there's no way to know 100% before surgery if it's going to work. But once you get in and you see this type of scar tissue, the white stuff here, and the calcium in the scar tissue, you know this is not normal. This is a result of inflammation, and the inflammation comes from that blue stuff right there, stuck in the tear, causing inflammation. This is like a hard cheese right here. All right, what's the other question?
Next question coming from David, once more on YouTube,
Hi, David.
asking, I see white cotton-like matter and some blue and some red.
Yep.
Which of those is disc herniation, scar tissue, granulation, tissue, etc.? And which among those stuff is the goal of your procedure to take out?
That's a great question, David. The blue stuff is degenerated nucleus pulposus. The white stuff can be degenerated nucleus pulposus that is scarred up or just pure scar tissue. It's usually both, combination. The pinkish stuff right here is granulation tissue, which is blood vessels and nerves, nerve fibers. And then the gold stuff, when I hit it with a laser, like right there, is calcium. All of this needs to come out. It's all causing the pain in the patient. How does David spell his name?
It's spelled like David, but the last name the last name is Yisrael, so I figured it was David.
Okay, got it.
Yep.
I hope that answers your question. We're just about done with this disc. And by the way, people ask me, how do you know when to stop? I've been doing this long enough. I just cut a corridor, and that's usually when I stop. I go from the inside to the outside of the tear, and that's all I need to do. I usually go from end plate to end plate. That's the end plate over there. You guys see that just past the laser? That smooth surface is the end plate or bony plate of T11, superior end plate, and then on the right side would be the inferior end plate of T10. I don't see the inferior end plate of T10. It's somewhere over there just to the right. But everything's going well. We're almost done. This thing was bulging out hard, and it's like, look at all that. That goldish, orangish color stuff is all calcium. It's all abnormal calcium in the disc fibers that's there because of chronic inflammation and injury. It's normally not found here. We never get 100% of the herniation, by the way. We want to get 50% if we can. 50% usually is the magic number. You get 50%, your patient's going to be pain-free, symptom-free. But when you get more than 50, that's just bonus. I always try to get as much as I can. I think the most I've ever gotten was maybe 80. This laser is amazing. It's delivering incredibly powerful energy. There's nothing else in the world like it. It is the best treatment in the world. Here's a piece of herniation coming out. Up and out. Just about done. Here's a little more herniation right there. That's a big piece of herniation. I'm going to try to grab it out with the grabber. That's going to be better than me lasering it, if I can get it to come out. There it is. Good. Making great progress on this disc. Our patient, once again, is under general anesthesia for this case. Normally they're under propofol sedation, but because he has severe apnea and he's at high risk for a complication from the airway, if we don't intubate him, we decided to intubate him. And that's going to be the safest option for him, safest. So we don't like taking risk with patients' lives. We like to do what's safe for the patient, what's best for the patient. We have full capability here. Dr. Berndes has often told me we have better equipment than a hospital does for doing these anesthesia cases because we have everything you could possibly want. Hospitals, you have to go through committees to get everything, all these pieces of equipment. Here, you just got to tell me we need it and we get it. If it improves patient safety, we buy it. There's not a piece of anesthesia equipment out there that we don't have that would improve safety. We've actually pioneered new technologies in anesthesia here at Duke Spine doing sedated cases, and nobody else in the world has done it. We're the first to do it. That's the use of a CPAP machine, which we bought, and we put that on our patients that are prone with propofol sedation, and that's improved their safety of the procedure massively. Nobody ever did that before. We're the first to do it. Basically, just using a CPAP machine to force air into their lungs. It keeps them from obstructing, and you can monitor their
CO2. Right, Dr. B?
And we can change the levels of anesthesia a lot more safely and more efficiently when you have positive airway pressure.
And we can change the levels of anesthesia. This is Dr. Berndez's notes, words, more safely and efficiently when we have positive airway pressure.
We have a couple more questions.
Sure, we'll take them.
Next one coming from Lanu on YouTube,
Hi, Lanu, welcome back.
asking if a congressman wants to sponsor you to be a candidate for a Nobel Prize in medicine, would you allow it?
Absolutely. I think this should get Nobel Prize. Not that I want a Nobel Prize, but what I want is I want awareness of this technology. I want, if we had a Nobel Prize, then everybody would know about it, and then that could change the world, and that could make this available to the world. And then more doctors would want to do it, more hospitals would want to do it, more patients would have access to it. I mean, it would be the greatest thing. Anything, it doesn't have to be a Nobel Prize, but anything that would raise access. Our biggest problem is people don't know about this and people can't afford it. Those are the two problems. Because, you know, it's expensive to run a surgery center and do what we do. It's very expensive. You know, we're looking at almost $1 million a month in cost for our tiny little 20,000 square foot building. So where do you get that money? Well, if the insurance companies don't pay for it, you know, patients have to pay. And that's a lot of money to ask from people. So if a Nobel Prize, if you're saying that, I think that would make people say, hey, this should be covered, this should be available, and more people would do it. And then more people would be out of pain. There would be no more narcotic overdoses. There would be no more narcotic prescriptions written for pain that could be cured like this. It would be the greatest thing. That's my life's goal, is to cure people of pain in a way that's safe and durable and lasts their entire lifetime. And that's what we're doing, but not enough people know about it. And people are still getting these horrible treatments out there that are hurting them. I don't like to see people get hurt. All right, we're just about done. I'm looking at the fat in the epidural space right there. I think this is the back of the disc right there. I'm going to do just a tiny bit more and we're done. But we're now at the outside of the tear. We've gone from the inside to the outside. This technique, by the way, is not my technique. It's Dr. Anthony Young. He was one of my teachers for the lumbar spine. He describes the inside-out technique. It's a safer technique for the patient. And that's what I've always used for the transforaminal surgeries that I do endoscopically, inside out. And there's doctors that recommend outside in. I do not recommend that. I think that's a bad idea. This surgery has worked perfectly with a 99.6% cure rate of pain. If you're getting that kind of cure rate with no complications and it lasts the rest of the patient's life, why would you change it? You can't beat 99.6% cure that lasts their lifetime that doesn't have complications. There's nothing better than that. Why change it? You know, I don't want to change it. So I do what works, you know? And Dr. Young taught me this inside-out technique. He's a big believer, and he's now retired. I don't think he doesn't operate anymore, but he was a genius and a great man. He was taught by Dr. Camden. Okay, that's it. That is just some fat around the facet, and I've gotten all I can get safely. We've gotten enough, and that's going to fix the pain at this disc. All right, Henry, if you have more questions. Have we shown all the videos that we want to show?
We've shown the discogenic thoracic pain, but we have not shown facetic either.
Have we shown how to get rid of the discogenic pain?
Yes.
The DLDR?
Yes, correct.
All right. Let's show people the second most common cause of thoracic pain. It's not the disc, it's the facet. And a lot of people have facet pain. This patient had facet pain. We already fixed it. It's gone, 100%. Now he has just disc pain. So we already fixed his facets with the DPR, Duke plasma rhizotomy,
He has no more thoracic facet pain, but he does have disc pain. That's why we're fixing his disc. Okay, 2 down, 1 more to go. The fluoro in, show the video. What?
You don't want to finish this one?
No. See that, Henry?
Yes, we can.
7 millimeters each. And that pain that he's been living with for 20 years is going to be gone today. And he's going to be able to sleep and not have pain. And that's a miracle, because nobody else could take that pain away from him. All right, let's show them a video and then we'll take some more questions.
Copy that.
Great. So from that video, you guys can see when a facet capsule gets torn, the body tries to heal it through inflammation. Unfortunately, when you heal something like that, you got to stay still so it'll heal. But who's going to lay in bed and not move one muscle for 3 months while the capsule heals? Nobody. No human being is just going to lay in bed for 3 months while the capsule heals. So the reality is we injure our facet capsule with trauma. We get up and walk around and do stuff, and that causes the capsule to stay torn, and your body continues to try to heal it. And what happens then is, well, you keep tearing it and you keep inflaming it, and eventually over time you get a growth of granulation tissue shot. And look at the lung shadows there. You guys see the lung shadow? Show them the lung shadow shot. Yeah, it's the white thing.
Yes,
that
we do.
line. There it is. So he took a breath out right there, and then the other one was a breath in. Just for reference. Okay. When you inhale, and it contracts when you exhale. Yeah, it's fine. All right, so here we go with the last of the 3 thoracic discs. And shot. He's got thick skin. Okay, hold on. Thick skin. I gotta make it a little bit bigger. Thick skin. Like literally, I don't know, 7 millimeters thick. And I'm on the correct channel, right? Yep, I am. Center channel.
Yes.
Yeah, he's just got thick skin. I think I have to cut some of the skin deeper down. Right here. Give it to me. On the top half. What are we doing next? We're doing the treatment for facet pain. There we go. That should do it right there. That was it. It was just getting caught up. Okay, we're in. Shot. See, that's a diagnosis right there, right, Henry?
Yes, sir.
When a surgeon assesses what's happening and makes a diagnosis and in real time changes course to fix it. That's what good surgeons do. They don't just do the same thing no matter what. You got to assess what's happening around you. You got to change, right? You got to evolve depending on your environment. Yeah, anesthesiologists do the same thing. So these surgeries aren't just static. They're not like, oh, it's the same thing every time. You got to be paying attention to what's happening everywhere. That's why there's so much that could happen. You got to be looking out for it all while you're doing it. It's kind of like swimming in the ocean, right? If you're swimming in the ocean, you're going to be looking for a shark. At least I am. I'm always looking, is there a shark coming? Because the shark can come at any time. They never tell you when they're coming. They're silent, they're hard to see, but it's the open ocean. And I do a lot of scuba diving, I do a lot of swimming in the ocean, I swim with sharks, but I'm always looking and assessing, And if I see a shark, I will definitely change what I do, because a shark can make a really bad day for you if you do stupid things with the shark. So just got to know it's there, got to be aware it could be there any minute, and you got to be prepared for its arrival. And that's what I do when I get in the water. I don't let the shark get me.
Of course, the most important thing with sharks is to know what kind of shark it is. There are certain sharks that it's okay, like a nurse shark. You know, I've been looking for nurse sharks for years. I'm trying to get a couple for my surgery center. That's a joke.
I was gonna say, I was like, I don't think they could fit in the fish tank.
Right? Yeah, take it out. But tiger sharks, great white sharks, those are the kind of sharks you want to know when you have a great white shark in the water with you. It's time to get the heck out of the water. Tiger shark, same thing. I see people online swimming with tiger sharks, doing stupid things, like pushing their mouth away when they come to bite them. It's just a matter of time. Tiger sharks are very aggressive. One thing that I learned shark diving was sharks can be very, very fast. That's one thing most people don't know, is that when you watch them on these YouTube videos, they're swimming gracefully and slowly. But I have seen sharks, they swim so fast you cannot keep up with them. Like, they will move their body so quickly. If you think you can block them with your hand, forget it. They are lightning fast when they want to be. They just act slow. Save energy, you know? We were in the Bahamas once with my kids, and these 2 6-foot gray reef sharks showed up. And we had been working with a team to get rid of lionfish, because lionfish are eating all the natural fish on the reef. So the government allows the locals in the Bahamas to remove lionfish. You know, you have to use a hand sling to do it. And we were working with this local group that was removing lionfish from the reef with hand sling. And of course, there's blood in the water. So once the sharks showed up to eat the lionfish we caught, and they were getting extremely agitated with the blood. They were moving so fast, you could not track them. They were like zipping around. I thought they were going to bite one of my kids. I freaked out a little bit. All right, that's a herniation right there I'm pulling out. Fresh out of the T9-10 left side, right out of the tear. We are inside the tear. That's the tear of the annulus. This is where all the pain comes from. You can see the red stuff, pink stuff, granulation tissue. Blue stuff, degenerated herniation, nucleus pulposus, basically. White stuff, that's the annular tear. For reference. Any other comments, questions?
Yes, we got a few comments and a lot of questions. This next one comment is coming from Joe on YouTube.
Hi, Joe. Welcome.
Saying, this is a comment and or seeking advice, saying, I just had a fusion and laminectomy on the 4th of November. Post-op pain management was absolutely horrible.
I'm so sorry to hear that. Yeah, Joe. I'm so sorry that happened to you. We try to steer people away from those types of surgery. Laminectomy's been around for almost 200 years. The first surgeon to do a laminectomy was a neurosurgeon called Victor Horsley, and he did it like in 1800s. It's significant for 2 reasons. Number one, he did it to take a tumor out of the spine that was making somebody paralyzed. So for a tumor, it's a great treatment. Get in there, get the pressure off the spinal cord, take the tumor out. You got to do a laminectomy. But people are doing laminectomies for back pain. They're doing laminectomies for pinched nerves, and they shouldn't, because a laminectomy will not unpinch your nerves, and it will not cure back pain. So doctors still do it, and I'll tell you why. They don't know any better, or they know better, and they just want you to have that surgery so that your spine becomes unstable, and then they do a fusion. I'm trying to raise awareness. Stay away from laminectomy, stay away from fusion. Someday, people like you're not going to, hopefully that's not even going to be an option anymore. They're going to take it away. You know, it's kind of like payphones, right? I don't know how old you are, but when I was growing up, payphones were everywhere. Every gas station, every supermarket, there were payphones. Now we have cell phones. Well, if you try to find a payphone, you're never going to find one. They're almost impossible to find. So they're gone. Basically, they took them away. I hope someday laminectomy and fusion gets taken away. They should only be reserved for like tumor infection and fracture dislocation, which is motor vehicle accident, high-speed fracture dislocation. Okay? Otherwise, this surgery will replace them. Keep it on. We're going to do this last disc, and then we're going to end the stream. We're going to come back right away with the lumbar part. We got to get the disc herniation out of the grabber. All right, let's take some questions.
Next question coming from David, once more on YouTube,
Sure.
asking, isn't granulation tissue a sign of the body's effort to heal the herniation? That's
You-
what I understand about granulation tissue formation in wound healing.
Yeah. So, David, you are correct. Granulation tissue is a stage of healing. It is a stage of normal healing. But granulation tissue typically is there for about a week or two, and then it's gone. Okay, gone. These people have granulation tissue for years and years and years because the inflammation never ends. You see, with normal healing, the inflammation is there for about 2 weeks to 4 weeks. And then you just get scar tissue formation, which with maturing of the scar for the year, the first year after injury. But when the injury never stops, the granulation tissue and inflammation never stop. And that's the problem. It's not the fact that there's granulation tissue, it's the fact that there's so much granulation tissue and it never goes away. It's always there for years and years and years. Okay? Normal wound healing has granulation tissue, but it's gone after a few weeks. This is not normal. That's why we do a debridement, to get rid of it. All right, next question.
Next question coming from Ramazan on YouTube.
Ramazan?
Ramazan, correct.
All right.
Asking, hi, Dr. Duke.
Hi, Ramazan.
This inflammation doesn't come back anymore after a couple years, including calcification and hernia?
Great question.
Because you're saying it can be permanently fixed. Thank you.
That is correct, Ramazan. The inflammation goes away permanently because what's happening here is I'm cleaning the tear by getting rid of the granulation tissue, herniated disc, calcium, scar tissue. And once this is cleaned, your body will seal it. Once sealed, there is no need for granulation tissue or inflammation anymore. It's sealed. The only reason there's granulation tissue and inflammation is because the herniation is there causing it. And your body is trying to seal the tear. All right, we're just about done. And we're going to end the stream. We're going to come back with the lumbar.
We have a couple more questions.
Sure.
Coming from Adam once more on YouTube, asking, I've got cervical stenosis, pins and needles, shooting pain down right, but my EMG came back negative for radiculopathy. Is this normal?
Yeah, it's not normal. So you have pins and needles shooting down. Your EMG came back normal. You have to have 20% or more damage to the nerve to get a positive EMG. So you may have sub 20% damage to the nerve causing those symptoms. That's the most likely explanation. There is another explanation. That is that your spinal cord is getting pinched, and that's why you have tingling. When you have a spinal cord damage, you get the same symptoms, numbness, tingling, paresthesias, but you don't have any finding on EMG. So it's either spinal cord injury or it's sub 20% damage that in the future will get worse, and then they'll see it. There's one more reason, and that is that the damage and the symptoms you have are less than 2 weeks or 4 weeks. 2 weeks? You need 2 weeks of nerve damage to see it on a nerve test. So you need 20% damage of the nerve to see it. You need 2 weeks of damage to see it at the earliest. Or you need, if you have spinal cord damage, it'll do the same, but you won't see anything on the nerve test. Those are the three reasons. Your reason is probably one of those three or a combination.
And last but not least, we have a question coming from Lubisa on Facebook.
Hi, Luisa, welcome.
Asking, does anyone in Europe do such a procedure?
No. No, Luisa, we pioneered it at Duke Spine in Florida. I'm Dr. Duke, I'm the pioneer. I'm very aware of all the treatments available in the world. I don't know every single surgeon in Europe, but it's never been available, and I don't think it's available currently. I could be wrong. Somebody could have started doing it last week, but I doubt it. It's a very complex surgery, requires years of training and experience, and people don't have that right now in Europe. Come to Florida and let us fix you properly.
And then lastly, we just have a few comments. This comment coming from Dino on on YouTube,
Hi, Dino.
saying, anyone looking for an amazing surgeon and phenomenal anesthesiologist and nurses, do not hesitate to see him.
Dino, you're very kind. Thank you so much. Thank you so much. It's good to hear from you, as always. We love hearing from our patients. All right, we are just about done with this third disc in the thoracic for this patient who hurt his back in work in New York 20 years ago. He hurt his thoracic and lumbar. He's been suffering with pain for 20 years. It's been getting better because he's been getting treatments here at Duke Spine for the specific causes. But he has this disc pain that we never treated, and he came back to us and said, it's killing me, help me. We figured out it was coming from these two discs, plus one in the lumbar above his fusion. We're going to do that next. So we're going to end the stream in a few minutes, and then we're going to come back with a L1-2 Duke laser disc repair. You're going to see he has screws and rods. I did not do that surgery. Somebody in New York did it, and he fused from L2 all the way down to the tailbone. So he's got metal. And now he's got a bad disc above the fusion called adjacent segment disease. That's the problem with fusions. You get a lot of adjacent segment disease. We're going to fix that next. But I need about 2 minutes left, 2 minutes on this, and then we're going to switch to the lumbar. We're going to end the stream. We're going to come back with a lumbar stream. So I apologize to everybody that we're going to have to end the stream. So get ready to go back and restart your stream for the lumbar. That's the end of the disc right there. You guys see that?
Yes, we do.
And you can see the junction between the disc and the fat in the epidural space. That's the fat at 12 o'clock, that fatty stuff, that yellowish stuff. But we are now done. The spinal cord is just behind the fat because this is thoracic. There is a spinal cord here, which makes this surgery more risky than the lumbar cases. All right. The tear is open, and we're going to take the tube. We're done. We're going to come back and do the lumbar. So we fixed 3 discs. Any other comments or questions?
Yes, we have a comment coming from Adam once more on YouTube saying, it's funny, I used to tell myself the only things I'm running to or from are the bathroom or the fridge. I'm adding sharks to the list.
Yeah. Well, not all sharks, Adam. You know, it's just great whites, tiger sharks. This is my opinion, bull sharks. You know, I would stay away from those kinds of sharks. But unless you're an experienced shark diver. Nothing wrong with diving with sharks. You go with somebody who knows what they're doing, and they don't do stupid things like feed the sharks. I've done shark feeding, not myself, but with a team. You know, as long as they know what they're doing, they position you properly, away from the food, you're behind rocks or something, I think it's okay. I know you see all kinds of stuff on the internet, but I'm kind of a nervous person when it comes to risk. I don't like risk. And I certainly wouldn't want to be in open water with a shark feeding. I got to take this one out. I misfired it. You have a little hemostat. So I put one of the staples in the incision. I'm going to take it out. I'll get it. I'll get it. Yeah. Any questions before we wrap up this surgery
Nope.
and start the lumbar?
No current questions.
All right. I always pinch to evert the edges. That way you get the perfect scar. It heals best that way. You can see there's no swelling or hematoma or anything. We're going to move on to the lumbar. You can go ahead and end the stream and we'll be back.